Several decades ago, smallpox, caused by the variola virus, was a menacing disease. Its deadly rash spread fear throughout humanity, but today it is almost forgotten thanks to the global smallpox eradication program. As smallpox was rampant despite the advent of vaccination, the WHO Smallpox Eradication Program slowly began between 1958 and 1966. It faced many challenges, but surveillance containment measures were crucial to its success. Global smallpox eradication emphasized public health systems' responsibilities, as well as the global population's rights and responsibilities, and shifted the perspectives of governments and the public regarding disease control and global cooperation. Smallpox was destructive throughout history. One of the earliest signs of the disease is the smallpox-like scars on the mummy of Egyptian pharaoh Ramses V, who reportedly died of an illness over 3,000 years ago. The disease typically had a 30% death rate, but killed up to 80% of the Aztecs when introduced to the Americas in the 1500s. Traditional treatments were ineffective, including erythrotherapy, the use of red color or lights. However, variolation was developed in Asia around the 10th century CE. This provided smallpox immunity but killed 2% of patients. In 1796, English doctor Edward Jenner created the first vaccine, which could effectively protect patients from smallpox. Yet throughout the 1800s, many saw vaccines as dangerous. For example, in 1879, a member of British Parliament declared that 13 cases of syphilis had arisen from one case of vaccination alone. By the early 1900s, most industrialized countries used mass vaccination to control endemic smallpox. In 1947, New York City officials vaccinated 6 million residents in response to a single smallpox death. Similar programs stopped smallpox in other industrialized areas, and cases dropped throughout North America and Europe. By the 1950s, smallpox was eradicated in industrialized countries, but remained endemic in the rest of the world. The WHO Smallpox Eradication Program began slowly, but intensified due to pressure from other governments. During the 1958 World Health Assembly, Dr. Viktor Zhdanov of the Soviet Union proposed a smallpox eradication program, since the USSR still continued costly vaccinations despite eradicating endemic smallpox in the 1930s. The proposal ended a 9-year Soviet absence from the organization during the Cold War. So, the WHO accepted the plan, as the Soviets responsibly contributed internationally towards smallpox eradication. Yet for 8 years, the WHO poured funds into a failing malaria control program instead, neglecting smallpox until 1966. That year, PAHO proved that smallpox eradication in remote areas was possible by eradicating smallpox throughout most of the Americas. Also, the US began funding smallpox vaccinations in West Africa, cheaply supplementing an existing measles program while preventing imported smallpox. Both Cold War superpowers responsibly cooperated to support smallpox eradication, which strengthened the right to global public health. So, in 1966, the WHO began an intensified smallpox eradication program, where the WHO would provide resources and technical knowledge to support countries in national smallpox control efforts. However, the WHO Smallpox Eradication Program occurred in difficult geographic and demographic environments while dealing with weak and unstable governments. A good case study is India's smallpox program due to its extreme challenges. Some in India believed smallpox was a sign of disapproval from the Hindu goddess Sitala Mata, causing Indians to misunderstand the disease. Dr. David L. Heyman, a WHO epidemiologist who worked in India's smallpox program, described the environment.
Sometimes we had to go on a donkey. Many times we walked across rice paddies, and there were some risks with snakes and different things. What the danger was driving at night, because there were what they called dacoits, or robbers who would put up roadblocks.
Despite these factors, Indian public health workers had to be socially responsible for providing the right to vaccination and public health services. Meanwhile, India's smallpox program nearly collapsed in 1967. At the time, health workers were punished for case reports, which were seen as failure to prevent smallpox. Thus, only 10% of cases were reported, and unreported smallpox could then spread uncontrollably. Additionally, the Pakistani Civil War of 1971 saw refugees from former East Pakistan flee to Indian refugee camps before returning to the independent Bangladesh. However, those refugees spread smallpox throughout India because the Indian government struggled to responsibly control smallpox in Salt Lake Camp, the largest refugee camp. Thus, cases increased 20-fold in 1972, showing India's struggle to uphold its people's rights to smallpox eradication and public health services. Surveillance and containment efforts were key to smallpox eradication, and both required cooperation with locals, effective government, and foreign investment. Surveillance entailed finding smallpox cases, so India's public health system, with WHO pressure, started rewarding instead of punishing health workers for reporting smallpox. It also announced monetary rewards to locals for finding smallpox cases and showed them the WHO smallpox recognition cards. India's government responsibly improved its reporting system, granting its people the right to support smallpox eradication. The people thus became responsible for helping health workers find cases for the betterment of their communities. With reliable surveillance, containment, or stopping cases from spreading, began with ring vaccination. This involved quarantining smallpox patients and vaccinating contacts, breaking the chain of transmission. During this, WHO officials responsibly hired locals to ensure trust with local Indians.
Well, many times they had never seen a European before, and so we had to be careful that we didn't frighten the people.
The people had the public health right to vaccination, but were also responsible for cooperating with health workers to protect their communities from smallpox. To fund these efforts, industrialized countries responsibly supported smallpox eradication by investing over $12 million in India's smallpox program through the WHO. But in 1974, India's case numbers spiked as severe floods caused refugees to spread smallpox. India's government, in shock, intensified eradication efforts, responsibly protecting its citizens' rights to smallpox eradication and public health. By May 1975, the last smallpox case in India was isolated. The WHO used strategies from India to eradicate smallpox in the rest of the world. On October 30th, 1977, the final smallpox patient, Ali Mao Malin, was isolated and treated in Somalia. And on May 8th, 1980, the WHO declared that the world had won freedom from smallpox. Ending smallpox vaccination had unintended consequences, but the lessons learned from smallpox eradication are valuable to controlling other diseases. First, smallpox eradication inadvertently caused Mpox to emerge. Following eradication, most of the world stopped smallpox vaccination due to cost and safety concerns, and smallpox immunity has fallen to less than 30% globally. This caused Mpox, which is preventable by smallpox vaccination, to infect over 80,000 people globally in 2022, but wealthier countries stopped smallpox by 2023. However, a more deadly strain of Mpox is currently ravaging Africa, with over 7,000 confirmed cases so far in 2025. While the US previously pledged financial support, such aid is now in jeopardy. Global cooperation, which made smallpox eradication possible during the Cold War, still remains essential to disease control today. However, on January 20th, 2025, President Donald Trump signed an executive order declaring the United States intends to withdraw from the WHO. He criticized the WHO's mishandling of the COVID-19 pandemic and other global health crises, among other reasons. Such criticisms are warranted, as during the COVID-19 pandemic, many governments withheld case reports, undermining global surveillance. However, just as during smallpox eradication, all countries, including the US, are responsible for working together and with the WHO to control disease worldwide. Also, during smallpox eradication, the people responsibly accepted smallpox vaccination, but today many endanger their communities by neglecting their responsibility to get vaccinated. During COVID-19, social media misinformation caused people to distrust public health advice. Thus, people refused to get vaccinated, prolonging the pandemic. We continue to see the impact of distrust in public health in 2025, as resistance to the effective measles vaccines caused the first measles deaths in a decade. People are responsible for following public health guidance to protect their communities. Global smallpox eradication proved that when social and political issues are set aside, public health systems and the people should be responsible for providing the right to public health for the world.